Some say too much of a good thing can be a bad thing. Hello, and welcome to our presentation on Priapism. I'm student Dr. Hannah.
And I'm student Dr. Swoboda.
And we're second-year medical students at the Idaho College of Osteopathic Medicine, working under Dr. Joseph Williams from the Idaho Urologic Institute. In this video, we will explore the tumescent realm of Priapism and use the American Urologic Association guidelines to shed light on the management of this condition.
But first, what are the AUA guidelines? The AUA's guidelines provide evidence-based guidance with an explicit clinical scope and purpose for urological chief complaints. These guidelines offer expert opinions and peer-reviewed treatment recommendations and research updates. Guidelines are reevaluated with scientific literature to ensure that the recommendations are current. During an erection, blood flows into the straight, dilated helicine arteries throughout the length of each corporal body. The venous drainage of the penis is mainly via the internal pudendal veins. Blood from the peripheral sinusoids travel in the trabecular network and drains via the subtunical venous plexus and eventually exits via emissary veins. During the erection, the emissary veins are compressed between the sinusoids and the tunica albuginea to limit venous drainage from the sinusoids and maintain tumescence. Problems occur when either there is low venous drainage or high arterial flow.
So what is Priapism? And Priapism is a persistent penile erection of greater than 4 hours that is unrelated to sexual stimulation. Priapism occurs at a low incidence rate. However, due to its progressive nature, Priapism is a situation that both urologists and emergency medicine practitioners must be familiar with and comfortable managing. There's two different kinds of Priapism: ischemic, which is non-flow, and then non-ischemic, which is high flow. Quickly identifying the differences between these two pathologies when presenting with Priapism will allow for a swift response to manage it. Ischemic, which is veno-occlusive, low flow, is characterized by little or no cavernous blood flow with hypoxic cavernous blood. The corpora cavernous are fully rigid and tender to palpation. Patients typically will report pain on this. And the natural history of untreated acute ischemic priapism includes days to weeks of painful erections followed by permanent loss of erection function. Acute ischemic priapism is a medical emergency and requires prompt evaluation, and in some cases, emergency management. Non-ischemic, or which is arterial and high flow, is related to unregulated control of arterial inflow and cavernous smooth muscle tone. Erections are nearly always non-painful, and cavernosal blood gas measurements are consistent with arterial blood. In contrast to acute ischemic priapism, the non-ischemic variant is not considered a medical emergency. For non-ischemic priapism, clinicians should counsel patients that non-ischemic priapism is not an emergency condition and should offer patients an initial period of observation. Once diagnosed, the clinician should consider a penile duplex ultrasound for assessment of fistula location and size. After a trial of observation in those who wish to be treated, the clinician can offer embolization as the first-line therapy. Patients should be informed that embolization carries a risk of erectile dysfunction and recurrence and failure to correct non-ischemic priapism. If the first attempt does not succeed, then the urologist might offer a repeat embolization before surgical ligation. One of the goals of priapism treatment will be to preserve erectile function, which is diminished as the tissue becomes necrotic, which only will be seen in ischemic priapism. So, moving on, we're going to now use a case that we've more or less adapted from the AUA guidelines on acute ischemic priapism. GJ is a 36-year-old man presenting to the emergency department due to a painful erection that has lasted 12 hours. He's tried masturbation and ice packs without detumescence. According to the AUA Guideline Statement 1, in patients presenting with priapism, clinicians should complete a full medical evaluation with a physical exam that includes genitalia, abdomen, and perineum. A comprehensive history is the mainstay of priapism, and history should point to the underlying type of priapism. Additionally, the history and etiology may determine the most efficacious treatment. The historical items to be gathered would be penile function and duration of the erection, as well as degree of pain. And then moving on into the history, you'd really be looking into if there is a risk of sickle cell disease or if they have it. Moving into medications that can also cause priapism, you're really kind of looking at several different agents, which include anticoagulants, anti-anxieties, antidepressants, antihypertensives, hormones such as testosterone, and recreational drugs. During the interview with this patient, you learn that he has a history of ADHD and asthma and reports having intimate relations with his partner the night prior. He also reveals taking 50 milligrams of sildenafil that he obtained from the internet website. GJ also remembers having an episode in the past and then reluctantly reveals that he frequently uses intranasal cocaine prior to sexual intimacy. Physical exam of the genitals presents the corpora fully rigid and tender, while Gland's penis was soft. This is suggestive of ischemic priapism, which is an emergent case. According to the AUA Guideline Statement 2, clinicians should obtain a corporeal blood gas at the initial presentation of priapism. And on aspiration of the blood of the erect penis, you find the blood to be dark red, which is consistent with hypoxia from the ischemic priapism. GHA's values from the blood gas had a partial pressure of oxygen of 18, partial pressure of CO2 at 83, both in milligrams of mercury, and a pH at 7.05. Using the table that we provided above, it shows that it is within the range of ischemic priapism, so we're going to move forward with that. And using kind of AUA's Guideline Statement 5, in a patient with diagnosed acute ischemic priapism, conservative therapies which he tried are likely to be unsuccessful, so we should not delay with more definitive therapies. Looking further into that, you really see that the use of home remedies will be imprudent and will only delay detumescence. Such treatments outside of cold therapy and masturbation include using heating pads, vigorous exercise. Oral medications like terbutaline, pseudoephedrine, digoxin, gabapentin, or hydroxyurea are not recommended due to low reported success rates. This is due to the attenuated corporeal blood flow leading to poor intracavernosal medication concentration and therefore failure to detumesce. Back to our patient. We've determined that the patient has ischemic priapism after a thorough history, physical exam, and blood gas analysis. If a urologist is on the way, then you can use this time to counsel the patient about the chance of erectile dysfunction. In addition to permanent loss of erectile function, untreated priapism can result in penile shortening as a consequence of corporeal fibrosis. Delay of time of definitive treatment with priapism, you will go from having almost full regain of all erectile function to no erectile function after 36 hours. On a cellular level, interstitial damage is time-dependent, with edema and thickening is seen on the first 12 hours. After 24 hours, necrosis of the cavernous smooth muscle develops. With the necrosis, infiltration of fibroblasts lead to cavernosal penile fibrosis and is inevitably going to result in ED and penile shortening. Once the urologists arrive, they will begin the primary treatment of ischemic priapism, which is outlined in these next two statements, that the clinicians should manage acute ischemic priapism with intracavernosal phenylephrine and corporeal aspiration, with or without irrigation, as a first-line therapy and prior to operative interventions. And then 9 is, in addition to these injections of phenylephrine, you should also be monitoring blood pressure and heart rate. If the ischemic priapism is less than 4 hours, then treatment with intracavernosal injection of sympathomimetic drug, such as phenylephrine, should work. After 4 hours, then optimal treatment includes corporeal aspiration with or without irrigation combined with injection of phenylephrine. For this patient, you or the urologist will use a non-heparinized 19-gauge butterfly needle and place it into the corpora via the glands or the corporeal shaft and remove approximately 10 mils of blood to decompress the corpora. Now, phenylephrine is mixed with saline to a concentration of between 200 and 500 micrograms per milliliter, and that can be injected into the corpora at 1 mil aliquots every 5 to 10 minutes. You'll repeat these injections until resolution or the decision to continue this treatment is futile.
Back to our case. Unfortunately, detumescence does not occur after intracavernosal phenylephrine and aspiration with or without irrigation. From this point, the clinician should obtain a surgical consult. AUA Guideline Statement 10 says that urologists should conduct a distal corporal granular shunt with or without tunneling after intracavernosal phenylephrine and aspiration. Surgical treatment is considered second-line therapy of ischemic priapism and is indicated if repeated corporal aspiration and phenylephrine injections fail. Surgical management consists of penile shunt surgery and penile prosthetic implants. Penile shunt surgery aims to create a fistula between the corpora cavernosa and the spongiosum to encourage the outflow of ischemic blood and restore normal circulation. Open surgery is also an option, which requires removing the distal tip of the corpora bilaterally to allow blood to drain into the spongiosum of the glands. During the shunt procedure, the urologist should carefully consider the utility of performing a cavernosal smooth muscle biopsy. If smooth muscle necrosis is present on biopsy, future irreversible erectile dysfunction is likely. This information will help the patient and urologist decide if a penile prosthesis is appropriate in the intermediate or delayed time frame. A few studies have demonstrated that adding a tunneling maneuver to the distal shunt procedure can increase the success of detumescence. This technique is the passing of a slender instrument or dilator through a distal tunicle opening into the corpora cavernosa in a retrograde fashion to assist in fragmenting and evacuating clotted blood. Back to our case. After admission to the hospital, the patient was taken to the operating room for a distal shunt procedure. A T-shunt was performed along with tunneling with a 12-Frank Keir dilator. The patient enjoyed detumescence for several hours before noticing that his erection had returned. If an erection persisted following a shunting procedure, the urologist should perform a corporal blood gas or colored duplex Doppler ultrasound before repeat surgical intervention, according to Guideline Statement 13. Often, the patient experiences recurrent tumescence after shunt surgery. It is imperative to differentiate whether this represents recurrent priapism or reactive hyperemia. The AUA guideline panel has recommended that the treating physician obtain a corporal blood gas measurement or a colored duplex Doppler ultrasound. Corporal blood gas helps measure cavernosal oxygenation to determine the presence of ischemic blood and recurrent priapism. The role of imaging is to assess the cavernosal blood flow, suggesting that the previously performed shunt remains patent. The limitations of performing a duplex Doppler ultrasound include the following. The exam is operator dependent. Accuracy may be compromised when using the imaging modality after a penile procedure has occurred. The potential lack of availability in small of rural hospitals. After obtaining either a corporal blood gas measurement or a color duplex Doppler ultrasound, the clinician can make an informed decision if tumescence after a shunt procedure is recurrent priapism or reactive hyperemia. Back to our case. After confirmation of recurrent erection, a penile Doppler ultrasound was ordered to ascertain current penile hemodynamics. The duplex Doppler ultrasound revealed no discernible flow across the T-shunt, and it showed no cavernosal blood flow. It was determined that the patient was indeed experiencing recurrent priapism. Urologists should consider a penile prosthesis in a patient who has priapism refractory to shunting, according to Guideline Statement 14. Treatment-resistant acute ischemic priapism lasting more than 36 hours usually results in the permanent impairment of spontaneous erectile function. Additionally, the ensuing fibrosis will result in penile shortening and possible deformity. Consideration of immediate placement of a penile prosthesis is prudent. Special attention should be given to the informed consent process. The physician should discuss corporal blood gas results, the chance of regaining erectile function, and all the risks and benefits to prosthesis placement. Penile prosthesis implantation in the setting of priapism has additional complications as compared to routine inflatable penile prosthesis implantation. There is an increased risk of infection and erosion. Additional complications include cavernositis and an increased risk of revision surgery. Early insertion of a penile prosthetic reports higher patient satisfaction, and delayed implantation greatly increases implantation difficulty and complexity. Back to our case. The patient was presented with the possibility of the placement of a penile prosthesis. After asking numerous questions, he consented to the surgery. The patient underwent successful implantation of a 3-piece penile prosthesis through a penoscrotal approach. His post-operative course was uneventful, and he was discharged the following day. 6 weeks later, at his post-operative appointment, he was able to inflate and deflate the device without difficulty. In summary, priapism is an uncommon, poorly understood problem that needs additional research. Conservative therapies such as oral medications, exercise, and cold showers are not recommended and can delay treatment. The issue should be managed with aspiration and injection of alpha-adrenergic agents, followed by a distal shunt with tunneling. Duplex Doppler ultrasound is useful in the evaluation of a persistent erection after previous priapism treatments. Significant erectile dysfunction occurs after ischemic priapism has lasted more than 24 hours, and complete erectile dysfunction is expected after 36 hours. In prolonged or refractory cases, the placement of a penile prosthesis should be considered. Early penile implantation has the advantage of avoiding corporal fibrosis while preserving penile length and girth. Research endeavors should focus on understanding the basic physiology of priapism, identifying new pharmacologic treatments, and comparatively evaluating new treatment options. Now that you are more familiar with the AUA guidelines on priapism, you can be more confident in educating your patients on the correct diagnosis and management of ischemic and non-ischemic priapism.